recording.
Greetings. Today I will be teaching how to recognize risk for suicide utilizing case studies. The students today are registered nurses who are experienced but are new to psychiatric nursing. Every year 30,000 Americans take their own lives. Many of you may have experienced a patient suicide. Others may have conflict or contact with a patient who is contemplating suicide or has attempted suicide. In order to provide early intervention, it's very important that you're able to identify and assess for the patient who is at risk. Using the mnemonic "is path warm" is an easy way to remember the signs of suicide. I is for ideation, which means threatening to hurt or kill oneself, looking for ways to hurt or kill oneself, talking or writing about death. S is for substance abuse, increased use of drugs or alcohol or excessive use of substances. P is for purposelessness, no reason for living, no purpose. A is for anxiety, agitation, which also includes an inability to sleep. T is feeling trapped, no way out, is resistant to help. H is hopelessness, a lack of hope about the future. Things are not going well, things are not going to change. Their perception is what is important, not the reality. W is for withdrawal. That is isolating from friends and family or society. A is for anger, either at oneself, such as self-loathing, at others, having rage or uncontrollable anger. R is for recklessness, engaging in a risky or reckless behaviors. M is for mood changes, sudden changes, dramatic mood swings, and they can be within hours. It's vitally important for you to be aware of the risk assessment data of your patient, either by reading the chart or finding out through interdisciplinary team meetings. Risk factors of the patient can usually be found in the chart under the psychosocial assessment performed by the social worker and the psychiatric evaluation performed by the psychiatrist. So for risk factors, we have past psychiatric history, previous diagnosis indicates a vulnerability, alcohol and other substances, previous psychiatric treatment and response to treatment, whether there is a response or if it's poor response. Comorbidity, which is dual diagnosis, which means a psychiatric illness coupled with chemical dependency. History of physical, sexual, or emotional abuse or trauma. Family history of mental illness, suicide attempt, or completed suicide. So included in risk factors are stressors. These may be external stressors and social events that affect patients differently. So number one is financial loss, which typically males experience greater stress than females. Number two, relationship breakups. Adolescents cite relationship issues as triggers for suicide more than other age groups. And number three, the death of a spouse. Usually elderly males who survive their spouses cite this as a factor in their suicidality more often than females. In addition, times of transition can also place patients at a higher risk. Treatment setting changes within the first few days of admission, when nearing discharge, and within the first few days after discharge. Also, when there are caregiver changes, when a team member goes on vacation, when there are residency rotation changes, etc. And even when nurses are on vacation, oftentimes our patients will express some distress. Where's my nurse? I need her. Protective factors are an important part of assessing for risk. Although protective factors don't negate the risk for suicide, they can balance or decrease the person's overall risk for suicide. Protective factors include the presence of a life partner or having other strong relationships, social supports such as belonging to groups, clubs, and identifying a network of friends, cultural traditions and influences such as belongingness and acceptance, religious or spiritual beliefs. Spiritual values provide a sense of meaning and protect against despair and can decrease the likelihood of acting on the suicidal ideations. Number five, individual strengths and skills. And number six, a willingness and motivation to commit to treatment. This can provide relief for medical, substance, and psychiatric issues. So students, we have two case studies that we're going to briefly go over. As I read this aloud and the students read along, let's think about identifying risk factors as well as protective factors, identifying relevant information, and determining the immediate risk of suicide to this patient. Charles is a 75-year-old retired man who continues to express that he just can't seem to come to terms with the death of his wife of 55 years. He states that he is extremely angry because she was hit head-on by a drunk driver. He states that sometimes he thinks it would just be better if he went to sleep and didn't wake up. He states that he has experienced great difficulty with getting good sleep over the past year, and that he's begun to drink wine in the evening to make him sleepy. When asked, he pauses and states he thinks he is drinking a bottle of wine every night and has been doing so for the past 6 months. He states that his 3 daughters and their families have been very supportive, and that his greatest joy is when they are all together. It makes me temporarily forget the pain of losing my wife. He also states that he has several friends he meets with each week, and that he and his faith gives him strength. He says that seeing a psychiatrist over the past 6 months has been helpful, and he is willing to stay in treatment. So students, can you name some of the risk factors?
The death of his wife.
Okay, very good. Death of his wife. Yes, that's one.
I would say anger.
Yes, anger. Very good. Okay.
Suicidal thinking, when he said it would be better if he didn't wake up.
Very good. Yes. Any other ones?
I would say lack of good sleep and his alcohol use.
Yes, those are very, very good ones. What are some protective factors?
His family, his daughters and their families.
Good. Any others?
He identifies that he has several friends.
Right. Very good. A sense of belongingness. Anything else?
His faith gives him strength.
Okay.
And also, he's in treatment and is willing to stay in treatment.
Very good. That is a protective factor. Okay, so let's go to our second case study. This is Jamie, a 16-year-old female high school student. Her parents report that she is not her usual happy self. Her biological father committed suicide when she was a toddler. She states that she does not have a good relationship with her stepfather, who has been in the household since she was age 4. She states that she has a good network of friends, and she frequently talks about her friend Lisa. She talks about being socially active and admits to smoking marijuana once or twice, but states that it is not something she engages in routinely. She states, "I'm not much of a partier." Jamie states, however, that she has been thinking of ways to kill herself for the past 6 months. She is vague about her reasons why, but that life, school, and friendships are stressful, and she doesn't want to continue living with the stress. She states that she hasn't told her parents that she was sexually abused by a female babysitter at the age of 11. She continues to carry a B average in school, and there aren't any particular problems with friends. Although Jamie has been in treatment and has not missed visits with her therapist, she arrives one day looking very depressed and anxious. She admits that she has not been sleeping over the past few weeks, and after some minutes of silence, she states that her friend Lisa has a new boyfriend and has not spent much time with her. She then states that she has an attraction to Lisa that is more than friendship. Following this statement, Jamie quickly shuts down and wants to leave her session, but agrees to stay until the end. She mentions nothing more about the dwindling friendship with Lisa or her attraction to her. When the session ends, Jamie rushes out the door, tearful and clearly upset. What are the risk factors?
Her biological father committing suicide when she was younger.
Yes, a family history of suicide, yes. Anything else?
She has a poor relationship with her stepfather.
Excellent. Anything else?
She admitted to thinking of ways to kill herself over the past 6 months, and she doesn't want to continue living with the stress.
Correct. That's very important. When a patient actually expresses a thought of not wanting to live or actually saying, "I want to kill myself," that is a huge red flag. Anything else?
She has a history of sexual trauma.
Yes, absolutely. That's one of the risk factors. Anything else?
No, she's depressed and anxious and not sleeping well.
Correct. Again, there's that not sleeping.
And her friendship with her friend is changing, and she has a sexual identity issue.
Correct. And again, with risk factors, this is an adolescent who has expressed that an adolescent citing relationship issues is one of the risk factors. And again, trauma, sexual abuse, emotional abuse, those are very much red flags. Any more? Okay, so what about protective factors?
She identifies that she has a good network of friends.
Okay, all right.
And she has been in treatment.
Okay, all right, very good. Okay, So those are our case studies. Okay. So it's important that there's an ongoing assessment of suicide risk in your patients. Factors that can increase risk for suicide can happen very quickly and can be unpredictable. Where others may present with increased risk, many are at chronic risk and so may present with ongoing suicidality, and others may be at increased risk during times of transition or other stressful specific events. So what's important is continue to assess your patients for the risk of suicide. Although difficult, accept that the patient has thoughts of suicide and validate their strong feelings and their desire to be free of pain. I hope this has been helpful as you begin your career in psychiatric nursing. Thanks for joining us.